My secret is out. I am actually a psychiatrist, and if I don't want to give away all our tricks of our trade, but this is a typical psychiatrist session. What I like to talk about, the focus is on diabetes, but I think what I'm going to be saying is applicable to any chronic disease that you're managing. For any chronic disease, there's a prevalence of depression and anxiety, although I'm not going to be talking about anxiety. There's probably twice the rate that you would expect in the general population, and almost universally, if not treated, leads to poorer outcomes, increased mortality, increased morbidity, and worse self-care. So we have more data on diabetes because it's been studied more, but the same applies, as I say, across the board. So what I'd like to talk about, a little bit about the prevalence, detection, because I think in some ways that's the single most important thing that you need to be able to do. Go through managing, just say a couple of words about motivational interviewing, self-management support, and then talk about some of the newer antipsychotics because they are diabetogenic, and I think there are a couple of things that you can do when you're introducing any of those medications. So firstly, the prevalence, twice as high, prevalence of depression twice as high as amongst the general population. Depressed patients with diabetes have poorer glycemic control, more severe symptoms, disability, added complications, and higher healthcare use relative to patients with diabetes and no depression. 71% of diabetic patients had a lifetime history of one or more psychiatric illnesses, usually depression or anxiety, not only, but those are far and away the commonest. There is some interesting evidence about the link between schizophrenia and diabetes, and this has been known for 80 or 90 years, and it still holds good today. But other than that, these tend to be either secondary to the onset of diabetes or comorbid pre-existing questions. And one of the first steps when you're assessing or thinking about depression in someone who has diabetes is to ask yourself, is this a new problem that is secondary to the onset of the diabetes, i.e. caused by the presence of a chronic disease, or is this a pre-existing condition that has either recurred or presented for the first time? Because remember, the majority of people who have depression get no treatment. Not necessarily over their lifetime, but the majority of people with depression or anxiety don't get treatment over the course of a year. So it may be coincidental that that comes to your attention. So always be thinking about those two pathways, because they can lead in slightly different directions when you're thinking about treatment and when you're assessing how well someone is doing. The other thing that is absolutely critical in this slide is that, and this is US data, but the Canadian data, surveyed by the CDA a couple of years ago, almost exactly the same. About 5% of people who are depressed and have diabetes get, it says optimal care, but in many instances you could say any care for their depression. So despite the cost, despite the impact that it has on outcomes, despite the fact that this is either a preventable or a reversible problem in many instances, 95% of people with diabetes don't have their depression recognized or treated. And it's something that in any other aspect of medicine would be totally unacceptable, that we have a 5% detection and treatment rate for a treatable condition. There are lots of reasons why that happens, and I think part of it is just focusing on the physical as well as the emotional. So I would say in any situation where you're seeing someone with an enduring general health problem, always think about the physical aspects, the impact it's having on them, and the possibility that there's a pre-existing problem that needs some kind of intervention. Just in terms of management, and I'll run through each of these: detection, assessment, and then interventions. And you can see that most of the interventions are nothing to do with, psychiatry. Obviously medication and some psychotherapy, but all of those other things are just part of self-management support or helping someone kind of make lifestyle changes that are beneficial to any health problem. But I was saying that I think detection is, in some ways, the most important step, because once we recognize that there's a problem there, then we can begin to do something about it. Detection is far and away the most important piece. What I'm handing out is a screening instrument, which is the PHQ-9. It's one of the slides that I'll be coming to. But there are two very simple questions that you can ask in any clinical interview that are going to help you identify whether someone is depressed or not. And those two questions, which are the first two questions on the copy of the PHQ-9, are: over the last month, have you been feeling sad or blue? And the second one is, over the last month, have you got less pleasure from things you used to enjoy? Those, if you like, are the two of the core symptoms of depression. If someone answers yes to either of those, then there's a very high likelihood that they are actually going to have depression. And when I say depression, I'm not talking about a depressive illness. I'm just talking about somewhere along the spectrum of having a dysphoric mood to being actually quite physically disabled by their depression. These two questions, as I say, incorporate into any interview. In the Hamilton Family Health team, we have the dietitians routinely asking these questions when they see someone with diabetes. And if they find that someone has a positive answer to either of these two, the next step would be to fill in the PHQ-9, and then they would suggest that maybe they want to make a follow-up appointment with their family physician to talk about this some more. So the dietitians are not making a diagnosis, they're not getting involved in treatment, but they're just identifying that there may be a problem and saying, perhaps it would be a good idea to go about getting some help. And the other thing that we're trying to build into our system is that the dietitians would then follow up on a monthly basis just to make sure that if there was someone who had been suggested they visit their family physician, just to make sure that they did follow through. So this is a really useful tool that you just incorporate in the interview and just ask routinely and ask fairly easily. The PHQ-9 itself, how many of you are familiar with the PHQ-9? How many of you use it on a regular basis? This is becoming more and more the norm, the kind of most used screening instrument for depression in primary care, partly because it's short, it's easy to administer, it's patient completed, you don't have to ask them questions. And if you look at it, it has 9 questions which relate to the major symptoms of depression. The 9th question is, and on the form you've got, it's sort of divided up into 2 parts, but it's a question about suicidal ideation. Question 10, which isn't scored, is a question that just asks about functioning. Because in many ways, although you're going to be assessing someone's symptom improvement, how they're functioning is more relevant to how they're doing. And if someone is telling you that they're really having a lot of difficulty, even though their score may not be that high, then you'd probably be a bit more concerned than their score being a bit higher, but saying I'm managing and I'm able to do what I need to do. This is scored very simply. There's no weighting, there's no identification of any separate items. Each is on a score of 0 to 3. So the maximum score would be 27. And the nice thing about the PHQ-9 is it leads you to think about people who are depressed in different ways. Each of these scores leads you to a different set of interventions. Someone whose score is less than 5, you may not need or want to do anything. But one of the things that would be important is that if you think someone has a problem, just to make sure that although their score was 0 today, you ask it at least every 6 months, because things may change over that period of time. So don't assume that well today means well forever. 5 to 9 would be considered relatively mild. 10 to 14 would be moderate. Greater than 15 would be more severe. And then above 20 would be not the most severe, but you would think about different kinds of interventions. Once someone's score is above 20, you would probably want to look at referring out to a mental health service or a psychiatric consultation fairly quickly. Whereas a score between 15 and 20 suggests that someone is depressed but is manageable in primary care, and you can initiate the first steps. And I'll come back to each of these and just run through them in turn. The other thing which is very important and useful about the PHQ-9 is that you can use it as a monitoring tool. It's not just a screening instrument. And depression is a very difficult condition to actually measure. There isn't a blood test that says your depression level is 7.1, therefore you're doing well, or your depression level is 23, and therefore you need this. The PHQ-9 helps a lot, because when you're talking to someone, you say, how are you doing? Are you doing better than last time? Well, they'll say, well, I'm a little bit better. But what does a little bit mean? You know, are they improving, or are they a bit more comfortable talking about it? Or are they about the same, but they don't want to disappoint you because your drug's not working? So, you know, this gives you a little bit more objective information on whether someone is improving. You're going to balance. You're not just going to treat based on a paper score, but it'll give you a little bit more of a tool to be able to say, yes, perhaps I do need to do something differently. Because if someone's on an antidepressant for 8 weeks and their PHQ-9 score is going nowhere, then the chances are you need to change it. You could probably say the same even within 4 weeks. If someone has reached a certain level and they're on a certain dose of medication, but instead of continuing to improve to the point where their score drops to less than 5, they're stuck at 9, and you see that over a couple of visits, then again it suggests you need to do something different with your treatment. This, in a way, is how you sort of start to plan or develop your algorithm, because this will lead you into some of the next stages of treating. 0 to 5, nothing that you need to worry about. Obviously, routine health teaching. PHQ-9, 5 to 9, common, mild depression. And for PHQ-9 scores under 14, there's a lot of evidence that says medications aren't that effective, that exercise and lifestyle changes are as effective, and that psychological therapies may be the treatment of choice. It doesn't mean that you may not want to consider a medication if someone really does seem to be stuck and isn't improving or responding to other interventions, but it's not indicated as the first-line treatment. So when you're just thinking about someone with a score of 5 to 9, and for each of the groups I'm going to show you, this is part of everything, and then the higher score adds a few extra interventions you may want to consider. So did the depression appear before the onset of diabetes or after? I mean, big question, we talked about that before. The second one, rate your mood on a scale of 1 to 10. It sounds very inexact. You know, 1 is the worst you've ever felt, 10 is the best. But I actually like this and use it quite a lot. And I use it in 2 ways. One is just to get some idea from a person as to how they're doing, and also being able to monitor over a period of time. And usually it's fairly accurate. But the second thing is that I will also, before they tell me what their score is, I'll try and guess what I think they're going to say based on what they've told me. And if there are discrepancies, you know, they're coming across as being cheerful and they're bright and they're engaging, but they're saying that their mood is still 2 out of 10, then it suggests to me there may be something else going on. You know, that there may be some interpersonal factors that are contributing to the reason why they need to portray themselves as maybe being a little bit more depressed than they seem to come across. So it's just a little bit of a warning sign in that regard. Is the depression getting better or getting worse? Because if it's getting worse, it's not improving, that may be an indication that you need to consider a fuller assessment and look at other interventions. Are there things going on in a person's life that are potentially stressful? Always think about the individual in relation to their environment. So there's family, and there's work, and there's accommodation and social supports. Are there things happening in any of those areas that may be contributing to the problem? Because often depression is multifactorial. It's not just one thing. And often what you see, and it may be the presence of diabetes has sort of pushed the person past the tipping point, but it may not just be that one thing, and it's not just education about their illness, but they need to do with their marital situation or their kids' ADD or the worries about not being able to return to work before they're actually going to recover from the depression. So think about potential sources of stress. Exercise and lifestyle changes, I mean, these are applicable right across the board. As I say, evidence that exercise is more effective than medications for less severe forms of depression. The Stanford group is a group model around that supports self-management, helps with the adjustment to the presence of an illness. And if you look at the content, much of the content is actually related to mental health issues. Although the Stanford model is generic and people with any chronic disease will participate, a lot of it is focused on adjusting to the presence of an illness. And a lot of these things that focus on self-management support have one thing at their core, which is increasing the individual's sense of self-efficacy. I can better manage my own problems. I can better look after my own condition. And a lot of what we're trying to do is reinforce that, because when someone has a chronic disease, not only is there the problems of dealing with it, but sometimes there's a sense that things are a little bit out of control. You know, this is happening to me, I can't do anything about it. And what you're trying to do with self-management support is help someone get back in control of their own kind of destiny, if you like, but more importantly, give them the feeling or help them learn that they can take charge of their own condition. Again, routinely use the PHQ-9 at every visit. I think what's useful is to put the score in the EMR, not only so you can follow it from visit to visit, but sometimes, well, we know depression is a recurrent condition. We know 50 to 60% of people have a depressive episode are going to have another. And it can be helpful to look back 2 years, 3 years down the road so that you can see, yes, this episode lasted 4 months, but at this point they actually seem to do well, or this was tried and this really seemed to be helpful. So you're able to use that this time looking at what happened last time. Supportive counselling, common to any interaction. This isn't just depression, diabetes. It's any interaction, any supportive intervention that you're providing in primary care. They're very useful skills. They're very easy to apply. The most important one is that you actually listen to what the patient's telling you. Because what you're doing, you're not putting yourself in the role of the expert. You're not going to take over. You're not going to direct. You're not going to tell. You're going to help and support the person to see how they can come up with solutions to the problems that they're dealing with. And it may be through providing information. It may be by helping them with a simple thing like saying, well, it sounds like you're feeling a bit overwhelmed because of all these problems. So why don't we break them down and let's look at the problems at home, and let's look at what's happening at work, and let's look at the financial problems. And why don't we try and work on one of them first and then start to work on the others rather than trying to deal with all at the same time. So you're helping an individual, supporting them to come up with solutions. But the reality is, you know, they're their problems. They're going to deal with them, and they're going to choose to deal with them how they want. And that's why it's so important that it's their plan and their goals and not yours. The other piece that's really important is to acknowledge successes. You know, when people do things that work or they're making progress, however small it may be, really reinforce that, because you're reinforcing that sense of, yeah, I tried something and it worked. You know, that sense of feeling good about their ability to look after the problems they're dealing with. And I think sometimes you may want to just gently challenge some of the assumptions they're making. Well, I'm never going to be able to deal with this, or my kid's going to be a problem until they go to university and then they're still going to bother me. You know, challenge those things. You're not going to disagree with them, but you're able to say, well, is that really the case? Or, you know, let's look at that another way. Or had you tried thinking about this another way? So that what you're doing is just helping a person to look at a problem from different perspectives. And the reality is, in any transaction that happens in your office, the patient is in control, however much we think we are. And if they don't like or understand or agree with what we're saying, they're going to do whatever they think is best for their health care. And often it's because we may not have explained it as well as we could have done. So, I think the more that we start with where the person is and build on that, the more likely there is to be a kind of successful implementation of what we're moving towards. General interventions, physical activity is something that I think is helpful in any chronic condition. I've used the word physical activity rather than just exercise. I think exercise tends to have slightly narrower connotations, but what we're trying to do is get people to exercise more than they have been. I find sometimes I'll even write a prescription for exercise the same way as I might for medication, just to walk for 10 minutes twice a day for 3 days and then increase it by such and such. And it actually does seem to make a difference. We've noticed the same thing with our childhood obesity program when we have a series of recommendations for an adolescent and they'll choose one of them. But if it's signed by the family physician as though it's a prescription, the people actually, the teenagers would take it more seriously. Craig, I was at a study, at a presentation, someone was talking about which health professional is the most effective in getting people to exercise more. Do you have any idea who it might be? The answer, believe it or not, is the vet. And there was a study done that said people are much less likely to exercise if they're told by their physician that they need to exercise more, or even if they're told by their physician or nurse that their kids need to exercise more. But if someone tells them their dog is overweight and needs to exercise, then they'll start walking. It's strange. I mean, it's one of the things that motivates me. So one of the things I like to ask people a lot is whether they could walk their dog. Nothing specific about diet and depression. There's no direct correlation between specific kinds of foods, but it's really just a healthy lifestyle. For a couple of reasons. One is because it's a change that you're making, and you may feel, this is good because I am doing something about my weight. But the other thing is that many of the medications that we prescribe, antidepressants and some of the other neuroleptics, have weight gain as a side effect. I'll say a word about the neuroleptics, the antipsychotics, towards the end. But even with antidepressants, there is a much greater likelihood of putting on weight. It does increase the appetite. There's some that are particularly prone to do that, and I think paroxetine and venlafaxine kind of fall into that group. So being able to diet, being able to eat more healthily reduces the likelihood of medication side effects. An aspirin a day will help prevent a heart attack if you have it for lunch instead of a cheeseburger. Sleep hygiene, also important. Lack of sleep is one of the symptoms of depression. Too much sleep can also be a symptom of depression. But we know that if people get a good night's sleep, it's likely to accelerate the recovery from a depressive episode. So there are a number of things that you may want to use for sleep, but one of them that there is some evidence that if you're starting an antidepressant can be helpful is the use of tryptophan. Tryptophan is triptan. You may need to use it up to 3 grams a day or even higher, and increase it gradually. Tends to have fairly few side effects, but the major ones are just sedation the next day. The other thing that's interesting about sleep is that if, it's not an exact rule of thumb, but an hour of sleep before midnight is worth a lot more in terms of refreshment and recuperation than an hour of sleep after midnight. So that if you can get to sleep earlier Even if you're getting up earlier in the morning, the same amount of sleep is going to have a greater benefit in terms of helping you not only with recovering from depression, but also just your general physical well-being. Goal setting, again, really important part of the management of depression, as it is with any condition. And again, the key is that the goals are the patient's. And I think too often where this breaks down is because we come up with what the person should be doing. And the reality is it ain't going to work. They're just not going to do it. And what we know, for example, with people starting on antidepressants, nearly 40% of people who stop antidepressants don't tell their physician because they don't want to upset them. So they're a bit embarrassed. It's not working, and I stopped it. So they'll pretend they're still taking it, and they'll get renewals. And it's the same thing with goal setting. What you're doing is not just kind of affecting the likelihood the goal is going to be implemented, but you're kind of truncating the relationship as well, because you're making it a bit less likely that the person will come back and engage with you around goal setting. Keep the goals simple. Begin wherever it is the person wants, because remember, it's not just the goal itself, it's the process of setting and attaining a goal, which again improves the way you feel about yourself. And review the goals on a regular basis. Make sure they're kind of integrated into a plan, but the plan is simple and the individual has a written copy of the plan that they take away with them. So that it's their plan, it's their problem, and they're the person who's going to be monitoring it. And they're also, if you give them a copy of the plan, they're the ones who are going to be holding the rest of the system to account. So the plan says such and such will call you about an appointment 6 weeks from now, and if they haven't called, then they will track down this person and say, you were going to call me, why haven't you done so? So goal setting, crucial, and I think these two things just highlight, make sure you and your patient share the same goals. Suddenly a heated exchange took place between the king and the moat contractor. So you really need to be heading in the same direction, and this not finding a common purpose has serious consequences. They both bitterly regretted lying to the dating agency about an interest in art. So again, you're working together, but it is the patient's agenda that you're working with. But it really is important to focus on where you want to start, because again, the more successful you are, the easier it is to build on that, the more confident you feel about following through. Education, information about depression, information about diabetes. I think it's something that we do badly uniformly. We do it badly partly because what we do tends to be very non-interactive. We just give people information. We don't follow it up. We don't ask them what they think about what it is that we've given us. Yeah, that's right. We give them stuff we know they're never going to read. There's a couple of studies that have said if you're giving people information, and they looked at how many pieces of information someone would remember and actually take away at the end of a session. What was the maximum number of pieces of information that someone would remember, do you think? Three. Less than 3. So if you gave someone 3 or more, they wouldn't remember all 3. However clear and concise you were, however educated they were, we just don't do it. We don't think that way. So again, when we come up with these educational resources, the literacy piece that Mike was talking about this morning is really important, but also just making it as simple as possible, the same messages that are repeated again and again and again, and really making sure that people understand what it is that we're saying to them. I actually had a call on Monday night from a patient who's in a nursing home, and she's about 75, and she called me to say she was very worried because there'd been an outbreak of D. syphilis in her nursing home, and she was afraid she might catch it. And I said, well, why do you think you might catch it? I mean, I've never heard of this. And my mind was sort of boggling a little bit about how you catch D-syphilis in a nursing home. And she said just because there are a number of people infected. But what was she actually talking about? C. difficile. So, I mean, she got the right end of the stick and the wrong end of the stick. But I think it's so important that we do take the time to check those things. You know, remember seeing a lady who was telling me she was getting up at 1 o'clock in the morning to take her antidepressants. And I asked her why was that. She said, well, my doctor told me to do that. And I said, well, what did your doctor actually tell you? 1 in the a.m. And she just thought 1 a.m. And we do it all the time. You know, we put it down on pieces of paper the same way as we do prescriptions. So one of the things that I like to do, and this is around changing medications, I'll always try and make sure now that before someone leaves, I'll have written down exactly what the plan is. And this is like a kind of paper dosette in a way, and you can do it day by day if you're changing more rapidly. But it just shows exactly what you need to do on each day and what you need to do with the particular doses. And at the bottom, there'd be sort of plans for contingencies. So if this doesn't work, do this, or if this happens, call straight away. When you look at the number of hospital admissions that come because of medication errors, that people just don't take their medication properly, the number of times that people don't recover because they forget that someone had said, if you're not doing well enough, then just increase the dose by another pill, and they think, no, I'm just stuck on this, and they're doing well enough, but they never recover completely. There's a story about a guy who went to see his family physician who wanted to give him a suppository. So he said to him, what I want you to do is take these pills, and every night I want you to stick one up your back passage. So this guy went home, didn't know what a back passage was, thought about it for a moment, and went outside his back door, put a pill outside his back door, and did the same thing every night for a week. Came back to see his doctor, and the doctor said to him, how are you feeling? And, he said, I'm not feeling any better. So he said, well, did you do what I said? He said, yeah, every night, doc, I put one outside, I put one up my back passage, but to tell you the truth, for all the good it did, I might just as well have stuck them up my arse. Lifestyle changes. How many of you are familiar with motivational interviewing? It's a very useful technique to have because it's based around Prochaska and DiClemente. You're familiar with this model? I think the reason that most of our education fails is because we assume that everybody is ready here. And we don't take the time to assess where they are, and we don't take the time to help to move people to the point where they're ready to do something differently. And you don't need to think about, other people. Just think about your own experiences, whether it's been making any kind of behavioral change, whether it's diet or exercise or smoking or drinking or anything like that. It doesn't just happen overnight. You need to go through those changes. And I think the key to motivational interviewing is that you're doing whatever you can to help to motivate the individual so they're ready to make those changes. So that they say, I need to do something about this now. And motivational interviewing is a way of moving people from the pre-contemplative or the contemplative stage to the point where they're ready to make, some specific changes. And you do that partly by helping to resolve or address some of the resistance to change. And you don't challenge it head on. You're not there to say to someone, no, you must do this now, because that's not going to work. But when you say, well, that's interesting, but I wonder, what difference do you think it would make if you were to cut down on your drinking? What difference do you think it might make to your family? Or how do you think your wife feels when you come home drunk on a Saturday night? So what you're doing is just getting them, it's based on the assumption that we're all ambivalent when we make changes. If we weren't ambivalent, we'd have made them a long time ago. There's a pull and a push. And what we're trying to do is increase the push that's within the person so that they can begin to say, yes, this is something maybe that I do need to take seriously or I do need to do something about. Changing behaviours and attitudes can be the biggest obstacle. I'm not asking you to change your spots. I'm just asking you to take out the garbage. Also, you may have heard about things like the 3-minute interview or the 5-minute interview, but these are things that you have in your pocket that you can use very easily. You don't get involved in a kind of major lifestyle change campaign. You just come up with a couple of ideas and you leave the person thinking, because they're ambivalent, and you're just changing the balance between, yes, I do want to move ahead, and no, I'm stuck where I am. So this is now the next step, and the PHQ-9 score is higher. This is more significant symptoms of depression. In this case, you would do all the same things you were doing before, but you'd add a few things. A slightly more comprehensive assessment, and I'll mention that in a moment, maybe a bit more regular monitoring. Involve the family. I think this is something we do way less than we should be doing. The presence of a chronic disease in an individual is the presence of a chronic disease within a family. And it is going to have an impact on other family members. It may be direct in terms of having to provide more care or support. It may be indirect because the person is not able to play the same kind of roles within the family that they used to. Or it may be anticipatory. They're worried about what could happen down the road. And I think in all of those situations, it's important just to think about the needs of the families. There's some interesting evidence looking at depression post-myocardial infarction. If you're depressed after an MI, your mortality risk over the next 6 months is 4 to 5 times greater than if you're not depressed. So you're 4 to 5 times more likely to die, and the risk is twice the risk of being a smoker. But again, we often don't pick up the depression, we don't treat it. One study that did look at treatment, and the disappointing thing is the studies that have looked at treatment of depression post-MI haven't had as big an impact on physical health outcomes as we'd hope. But they found that more effective than an intervention with the individual to treat them was an intervention with their partner. And that the partner interventions were more likely to lead to a better outcome for the individual. And why that was, I mean, you could explain it in a number of different ways. But I think it comes back to the point about involving the family all the time. I mean, FITs are family-centered practice, family health care. The treatments of choice are not medications so much as psychological therapies. How many of you are familiar with CBT, cognitive behavioural therapy? I mean, just with the basic concepts. Good. And the other treatment that would be included would be interpersonal therapy or solution-focused therapies. These are both treatments in the here and now. Cognitive therapy is, changing how you think about a problem and changing the way you react to certain stimuli that have a kind of negative effect on you. Interpersonal therapies are helping you look at particular problems that you're facing in your life and working out solutions. They're both short-term. Certainly there are models in primary care that suggest that you can achieve as much in 4 or 5 sessions of CBT as you can in 16 sessions. So these are useful treatments. So if you see someone with this score, this would be probably something to consider. And as I say, medication as an option if someone isn't improving. As far as the assessment of depression goes, a couple of things. First are the symptoms of depression. And this just summarise, this is just an acronym, SIG E CAPS. These are kind of the core symptoms that you'll find commonly in depression. They also occur in many other problems that you'll see. So don't automatically jump to the conclusion that because someone has 5 or 6 of these symptoms that depression must be the only cause. But certainly if we're using diagnostic classifications, if someone has 5 or more symptoms, then we would make a diagnosis of depression. And again, SIG E CAPS is just one acronym for remembering these different areas. And these are things, again, that you can just ask about. But if you're using the PHQ-9, a number of these are covered on that already. So you can just go with the answers that are on there rather than needing to inquire about these as well. So that with the assessment of depression, you're looking at the symptoms and you're looking at the severity, and you're asking the person to rate the severity of the symptoms. So that's obviously one piece of the assessment. What is the clinical presentation? Always think about comorbid anxiety. It's something I think that we often forget, but probably up to 50% of people who have anxiety, who have depression, will have a coexisting anxiety problem. It isn't always enough to make a diagnosis. You know, someone may have increased anxiety in social situations without necessarily making a diagnosis of social phobia. But one of the very common things to think about is generalized anxiety disorder. And there's also a very high overlap the other way around. Someone who has generalized anxiety is much more likely to have depression. The comorbid prevalence is at least 50%. Generalized anxiety is just excessive worrying about things that you don't necessarily need to worry about. It's sort of what-if worrying. What if this were to happen and that were to happen, then this could happen. It's worrying more often than not. It's worrying more than most people would. And it's worrying that takes a physical toll. It makes you feel tired. You actually feel the physical stress, or it makes it difficult to sleep. So just be thinking about comorbid anxiety as well, because sometimes that's the way an anxiety disorder will present. If you ask specific questions, you'll be able to diagnose them quite easily. If you don't ask, you'll probably miss it. Functioning is the third area. I mentioned before that functioning is important. Just ask someone, and this is covered on the PHQ-9 as well, but how well are they functioning, how well are they doing, and how much is the depression, the depressive symptoms preventing them from doing what they'd like to be doing? How much is it getting in the way of the things that they'd like to be doing? And again, use 1 to 10 rating scales. How well has someone come to terms with the presence of diabetes? So we're saying, is this a depressive disorder that's been present before, or is this an adjustment to a new situation? So just ask a couple of questions. You know, what was the impact when you found out you had diabetes? You know, have you noticed that you've been worrying about it more? And again, coming back to what Mike was saying this morning, you know, the people who kind of over-deny it and just want to get on in a matter-of-fact way, you know, may run into problems down the road because they haven't completely worked through the present. So again, I think those are people just to have a little red flag about. And then you're looking at two other areas. You're looking at factors that may have led to the onset of this episode: work, family, losses, financial stress, accommodation changes, and you're looking at specific risk factors. And you don't need to ask about a lot. Certainly, concurrent use of alcohol or drugs is going to slow the process of recovery from a depressive episode. Previous history of depression makes it either a little bit more likely that someone is going to have trouble, they're not necessarily just going to bounce back, or it may have consequences for the way that you want to treat it. Previous family history of depression, one of the nice things about this is that if someone if someone in a family has had depression and has responded to a specific antidepressant, that individual is more likely to respond to that antidepressant as well. And prior trauma as well. Assess the family. Look at how family's perception of how their relative is doing, how the family is coping. You know, same thing we were talking about before. The process of adjustment is similar for a family, but what's their need for information and support? What would be helpful for them? And sometimes they'll give you a completely different perspective. You know, someone will come into you and they'll say, I'm doing great, you know, things are going fine. And the family will come in and say, you know, they haven't been out of bed for a week. So you're just putting all the pieces together. It is multiple factors contributing, multiple points to intervene, and it may be that if you identify that there is a problem in a marital relationship, that may need to be the primary focus of treatment, because if that isn't addressed, the depression isn't going to improve, and if the depression doesn't improve, the diabetes is not going to be looked after as well as it could be. Then we go above 15, and the this is the point at which we may think about introducing medication. I'll come to medication in just a moment. I think we need to see someone more regularly. Once someone's started on an antidepressant, they should be seen at least monthly for the next 3 months, and monthly if they're not recovering until they start to improve. We often start people on medications, on antidepressants, and then we kind of lose track of them, or they lose track of us and we don't follow them up. So again, be thinking about this in terms of proactive care. And I would say I'd maybe change that to if someone hasn't responded to trial of 3 antidepressants, think about a referral. If you have a psychiatrist in your FIT or your CHC, they may be able to see that person. It may just be telephone advice. Once you get above 20, that's the point at which you may want to refer. But it may just be a question of saying, I've tried these couple of medications, they're not working, what should I do next? Become familiar with a couple of antidepressants so that you have your own approach. I'm going to start with this one. If that doesn't work, I'm going to switch to another one in the same class. If that doesn't work, I'm going to try one from another class. For depression, there isn't a great deal of difference other than maybe the side effect profiles, except there is some data that's come out in the last week, which I'll show you in just a moment, which I think does steer us in particular directions. But just get familiar with those kinds of medications, the ones that you're used to using on a regular basis, so you know what your stepped approach is. Here to here. If that isn't working, I switch to another group. And then if that isn't working, I may add a drug from another class. So I may put 2 antidepressants together. This is just saying refer to a psychiatrist. Obviously, there can be problems with finding a psychiatrist. It's not always this celebration when you find a psychiatrist. But clearly there are some problems with access. But I think the reality is that the vast majority of people with depression can be treated in primary care. They don't need a psychiatric referral, particularly if you have access to a mental health team or mental health resources. And this is the same thing about the access to psychiatry. We couldn't get a psychiatrist. Perhaps you'd like to talk about your skin. Dr. Perry here is a dermatologist. Medication. These 2 blues men having a problem. It's this damn Prozac. I haven't had the blues for weeks. A number of groups. The selective serotonin reuptake inhibitors, the SRIs, these are the most commonly used antidepressants. A study came out last week from someone called Cipriani in Italy. She did a review of all the randomized controlled trials of antidepressants that have been published, I think, in the last 10 or 15 years. And she looked at 3 criteria. She looked at how effective the drug was, what the side effect profile was, and the costs. And she found 1 antidepressant that was head and shoulders above the rest, and 1 that was shoulders above the rest. The one that was the head and shoulders was sertraline, Zoloft, and the one that came second was escitalopram. So that isn't to say that you need to switch to those medications, but I think you'd have to think quite seriously about why you wouldn't start with sertraline, and escitalopram is now in the formulary. So I must add, I have no interest whatsoever in any of these medications and would not propose one over another, except I think this was a fairly compelling study. These are the starting dose and the maximum dose that you can go up to. If you're treating anxiety, you may want to go a little bit higher than if you're just treating depression. These are the tricyclics. These are the older group of medications. They've been around for many years. They're as effective as the newer drugs, the SRIs and the SNRIs. The problem with these drugs is because of their side effects, they're less likely to be tolerated. So people are less likely to get a good therapeutic trial. But these are good alternatives to SRIs or SNRIs that you may want to consider. Also, if you're thinking about combination and you're adding an antidepressant from one group to an antidepressant from another group, it may be adding a tricyclic that works in a very different way to an SRI may be a very helpful combination to consider. These are the SNRIs, venlafaxine, duloxetine, mirtazapine. Bupropion is an interesting drug. It's dopaminergic and noradrenergic. It tends to be a little bit more energizing than some of the other antidepressants. It tends to work a little bit faster. It's one of the drugs that we would use for countering the sexual side effects of SRIs. So sometimes if someone is having sexual side effects and, from a drug like paroxetine, but they need to be on the medication because it's helpful, you can add bupropion and it may help to reduce the sexual side effects. And bupropion also is manufactured by a different company, different name, but exactly the same product as Zyban. So if you let people know when they're starting Wellbutrin that it may also reduce their desire to smoke if they are smokers. Just a few things about using medications. We used to say wait 4 weeks. There's a lot of evidence now that says if someone hasn't responded within 2 weeks to a new medication, that you need to increase it, because if they haven't responded in 2 weeks to that dose, they're not going to respond in 4 weeks. Usually when I'm starting an antidepressant, I'd start with the smallest possible dose to minimize side effects and then gradually increase. So even something like escitalopram comes in a 10 milligram pill, I'd start with 5 milligrams for a week and then go up. And the same thing with increases, I would go small increments. So I wouldn't necessarily jump from 1 pill to 2 pills. I may go to 1.5 pills to reduce side effects, but also because someone may respond to 1.5 pills. And if you've gone to 2, they may be on a little bit more medication than they may actually need. The withdrawal effects from some of these medications, particularly venlafaxine, but not only venlafaxine, really can be quite nasty. They can be physical symptoms. You can feel tired. You can get sort of electric shocks, almost tingling feeling going up your arms. The message is withdraw gradually. Absolute guideline would say 10% of the current dose every week until someone's off the drug, which would be 9 weeks. We can usually go faster. But always think about withdrawal effects. It's sometimes easier if you're introducing another antidepressant and you can introduce one while you're stopping the other. So you can start a second antidepressant and then gradually wean someone off rather than having to get them off and then start a new one. Mentioned before about monitoring progress, referring on. Rule of thumb, someone has been well on an antidepressant, stay on the medication for 6 to 9 months and then gradually stop it if this is their first episode. If you reduce it too quickly, you're increasing the likelihood of a relapse. Second episode, 18 months. Third episode, 18 months to 2 years. Fourth episode, may need to be on an antidepressant indefinitely. It doesn't mean you won't try them off, but you do for a first episode. If someone needs an antidepressant, you want to get them off as quickly as you can. But that means 9 months, not after you start the medication, but 6 to 9 months after they're feeling well. And I think you need to just be upfront about that from the very beginning. Just 2 other things I wanted to cover. One is just adjusting to the presence of the illness, some of the stages. This is Kubler-Ross model. It's grief, but it's applicable to any loss or any lifestyle adjustment. Just recognizing that people will go through a number of stages before they adjust, and they'll probably be going through the different stages at the same time. There are a number of potential losses. Loss of self-image. I am not a person with diabetes, I am a diabetic, and that has consequences when I talk to my friends or my family. I'm not going to be able to do things as well as I was able to do. Anxiety about what may happen down the road. And there are real losses, some things that down the road you may not be able to do or do as well as you could before. This is sort of the self-management approach. It's common to everything. We've talked about most of this, but the piece I would add is just giving people as much information as possible, giving them their records, all the data that they have, so that they know as well as much as they can about what their condition is. They become kind of the glue that takes that information to their different appointments. A couple of other things that you can consider: peer support. We have a peer support group in the Hamilton Family Health Team, 1-to-1 for individuals with diabetes and for individuals with depression. It's very different from the therapy they get from their mental health counsellor or dietitian, because there is nothing that can replace the experience that someone who has been that same route can give you. You know, learning from someone who's been that way and how they coped and how they managed can be so much more effective than hearing that from a counsellor. And again, Mike was talking this morning about the site which has patient stories, which I really would recommend. And the other piece is the Stanford model. This is a group that really focuses on adjusting to the presence of a chronic illness. But if you look at these, almost all of these are mental health related in kind of the broader sense, and lifestyle. So a big part of the Stanford model is lifestyle adjustments. In Hamilton, we're taking our group of peer support workers for our depression and diabetes program, and they're all going to do the Stanford training. So it'll actually be the peer support workers, the consumers, who will be running the group. And the last point I wanted to mention, we talked about the presence of mental health problems secondary to diabetes. There are also ways that we cause diabetes. Some of the newer antipsychotic medications, olanzapine, these are sort of ranked in the order they're likely to cause diabetes, contribute to diabetes in two ways. Part of it is through the weight gain, but part of it is because they seem to have a direct diabetogenic effect. They do actually cause diabetes through ways other than just increasing your weight. The average weight gain, 6 to 10 pounds in 10 weeks. The greatest weight gain is from 12 to 16 weeks. I've seen healthy young males who've developed type 2 diabetes within 6 months of starting on olanzapine. So again, really think about these risk factors. This is just guidelines. These are consensus guidelines from the American Diabetes Association, American Psychiatric Association, but basically saying at baseline, check weight, waist circumference, blood pressure, fasting glucose, and lipids, and then do all of those every 3 months. But measure weight at every visit, and if weight starts to increase and can't be contained, then switch to another medication. And again, a fasting glucose that's elevated is a problem. A glucose tolerance test that is positive is even more of a risk factor. If someone has a positive GTT, then you want to avoid these medications. Use the older ones, Haldol, Stelazine, Perfenazine. They're effective and they don't have the same kinds of side effects. And the last point is, if someone is on a medication, needs to stay on it, a couple of things that you can use to reduce the weight gain. One is Topamax, topiramate, and that can go up to 200 milligrams a day. And the second is metformin, up to 750 milligrams a day. So these are not necessarily people with diabetes. These are people who are on antipsychotic medications where you're concerned about wanting to reduce the risk or their weight is increasing, and just think about adding these two medications.